happy to be here with you in the third series of challenging cases. We know, as Dr. Ashwaq mentioned, the real practice sometimes is different than what we see in the book. And that's important to have a point of view of our colleague in different specialty and different hospitals. I'm glad to be here with my dear friend, Dr. Kanaan, to moderate the session, which is going to focus on cases in sarcoma and colorectal cancer. Dr. Kanaan is my friend as a consultant from National Guard Hospital with a special interest in sarcoma and GI cancer. So he's the right person to be with me in this sessions. I will give him the mic to introduce our first speaker.
Thank you, Dr. Abdul Rahim. And I thank Dr. Ashwaq, Dr. Mohammed for chairing this monthly meeting. So I think we will start with Dr. Ashwaq, who is our section head of medical oncology division at King Abdulaziz Medical City in Riyadh. I believe she will start by presenting a challenging case in sarcoma. So Ashwaq, the mic is yours.
Shukran Kanaan, shukran Abdul Rahim. So I'll start with our first case. So today I'll be presented two cases of sarcoma, but I thought it's a difficult case and challenging. So our patient, so the presentation will talk about the case, then we'll talk about the NGS and precision oncology in sarcoma and the rationale of use, and reviewing about NGS on sarcoma especially. And we will conclude. So our patient, he is a young guy, he's 35-year-old, diagnosed as a history of chondrosarcoma of the left tibia in 2010. He had FNA and report initially as myxoid epithelioid neoplasm, and he lost follow-up for treatment. Then he presented in 2015, and again biopsy done and reported as myxoid chondrosarcoma. He was seen by us, and he had a huge mass on the tibia, and in the lung, it showed bilateral lung metastatic. So we start him as usual with anthracycline-based chemotherapy. I give him iopofosine and ifosfamide, and after 2 cycles, he had no response, neither on the lung and not on the primary disease. So we thought, let's go stronger and give the MAID protocol, which have dacarbazine. And we give him 3 cycles. It's complicated by infection on the central line. And again, on the CT scan, there is no response. So we switch to the 3rd line to gemcitabine and docetaxel. And after 3 cycles, stable lung mets, and we discuss on the thoracic tumor board, he was not for metastatectomy. So the primary disease have to stay, since the patient was denied any therapeutic or curative resection for the secondary. So we thought maybe this kind of tumor might respond to TKI. We know that gleevec can work on soft tissue sarcoma, and we have evidence on that. So this is the first time that the patient switched from cytotoxic therapy, which is chemotherapy, to giving TKI. So when I give him imatinib 3 cycle, he progressed, although he was static on the 3 lines of chemotherapy. So imatinib was his 4th line. And then we have the data of pazopanib in soft tissue sarcoma, and we thought that's okay, maybe this will work on this patient. So again, we give him the treatment. After 3 cycles, he showed minimal decrease in his pulmonary mets. And after 6 cycles, he was having a stable disease, but unfortunately, he started to have high LFT. And the pazopanib was held, and LFT was normalized. Again, after resumed pazopanib, his LFT was climbing up. So we thought that's probably not the best therapy, although he had some response initially, but it does affect his liver badly. So we ran off option. We thought immunotherapy, we have the data that's that Pimpro might work on certain type of soft tissue sarcomas, certainly not chondrosarcoma. So we give him 3 cycles, then we thought maybe this is a pseudo progression after the 3 cycle. We give another 7 cycle, but still have stable disease. So it's kind that we run all of options. Patients receive all the curate or all the chemotherapy that works on soft tissue sarcoma. Patient, again, he received all the TKI possible on treatment of soft tissue sarcoma, and further a different line of therapy, which is immunotherapy, which turned to be his 6th line. Patient, amazingly, he's in a good health, he's fat. We thought, let's request an NGS. We know it should be requested earlier, but at that time we don't have the NGS in-house and we have to send it, and sarcoma was not of one of the indication of doing NGS in our hospital. But we requested after we failed all options. His NGS came positive to AWSR1, which is sensitive to Sutent. So we started the patient in Sutent in July 2018. Initially had a partial response, and we referred to ortho, and he had a partial response on more than one CT scan. So he was responding till he started to have some sort of a stable disease. So we call ortho since the disease in his leg causing a lot of symptoms. It was removed, and it was around 20 cm, 80% necrosis, and it was positive margin. And post-op, patient received radiation for the positive margin, and he remained in Sutent. So we continue in Sutent till last CT scan in June 2021. He still have minimal response to his lung mets, but unfortunately, the number of lung mets was not for resection. So now we're talking about NGS and sarcomas. So we know sarcoma is rare. It's 1% in adult. It's high in beads, and we have more than 50 subtypes, especially in soft tissue sarcoma. And if you're gonna go and read more articles, it's more than 80 subtypes. And in each subtype, we look at it differently because different patients with the same histological subtype, they act differently and they respond differently to treatment. And the treatment options are limited, and out of chemotherapy, everything is not 100% that might work, especially when we're talking about TKI. If we take only bazobanib, other TKI may and may not respond to this therapy. So as you know that soft tissue sarcoma is difficult because it's a heterogeneous group and there is multiple pathway on these patients, and the genetic alteration on these patients diagnostic and might predict the response on therapy, and definitely it's a prognostic. So understanding the genetic alteration, it will help us in getting the diagnosis and probably have better therapeutic option to the patient instead of giving the patient all therapy on the guideline, and we end up with a treatment that's not known to have to treat sarcoma, and eventually our patients respond to that. So we know from one of the clinical trial, more than 500 patients, they identify 41% genetic alteration that have therapeutic implication. And if you look here, if you look at soft tissue sarcomas, if we're looking at potential actionable mutation on these patients, it ranges from 50 to 60%. So I think NGS, it does have a role in soft tissue sarcomas. So if you look at liposarcoma as an example, CDK4 and synovial Ewing and rhabdomyosarcoma, and looking at alveolar sarcoma and hemangioendotheliomas, vascular endothelial growth factor had a good response, and you can name it. Going from each sarcoma to each sarcoma, and this is like a small part of the list. The list is longer than that. So, and also another example, we know there is ALK presence on inflammatory myofibroblastic tumor, and again, we know ALK fusion have been reported on a patient with Ewing sarcoma, and there is a few number of patients you might treat them with ALK inhibitors. So in conclusion, we know sarcoma is rare. Treatment is super difficult, and if we go with the standard of care, probably we are not giving the patient his best shot, not to expose the patient to too many line of therapy, and some of these line of therapy have potential toxicity, and sometimes you're gonna lose the window of getting the patient from non-curable to curable. So I think NGS should be done after failing first line of therapy, And especially on the subtype of sarcoma that we know that's rare, we don't have much of option, and we're not really sure even about the standard of care, which is chemotherapy, it might work on these patients or not. So by that, I will end. Thank you.
Thank you, Dr. Ashwaq. Definitely a challenging case. And you reached how many lines? 7 lines or 8 lines?
8 with Sutent.
8 with Sutent. I mean, this is remarkable. Unfortunately, I think with chondrosarcoma, we know that these types of tumors are very heterogeneous. With chondrosarc, we know that depending on the grade is how we can somewhat predict response. So you have your low grade that probably will not respond to any type of systemic therapy, whereas your high grade have some sort of sensitivity to systemic therapy. With your low grades, even with metastatic disease, although they do have low potential to become metastatic, but probably surgery would be the way to go with regards to having any type of response. Whereas it's somewhat the opposite with your high grades. Now, I congratulate you on managing those many lines with the patient and having some sort of response with the last line, so Sutent. It is, to be honest, a bit surprising to me that he did not really respond to pazopanib, yet he responded to Sutent. Both of them are broad category tyrosine kinase inhibitors. To be honest, I'm not sure how to explain this. I know, Dr. Abdulrahim, you do GU and you have some expertise with GU malignancies. And I know that you use both drugs with GU malignancies. Do you sort of see such differences in responses with pazopanib as opposed to Sutent and vice versa?
Yeah, so first of all, as you mentioned, congratulations for this case, and inshallah, tabarakallah, for getting the NGS. And this is actually a taste of our practice. Young patient, not following for some time, then coming and failing treatment with good functional status, and you know what to do next. Before answering your part of question, Kanaan, I think NGS is the future. Like, we're gonna go from categorizing disease as disease site to mutations, oncology, and this is, shows us that for pazopanib and sunitinib, usually both treatment excellently work in GU as multi-TKI. For me, if I get this patient, I would be worried with lung mets and pazopanib because of the history of pneumothorax for those patients, but it seems like it worked okay. And the same thing, giving patient with multiple lines, including doxorubicin, and carbazine, and sunitinib. At least I would worry about the heart, and imatinib in the middle. And mashallah, knocking on the wood, it seems okay. We do not use usually pazopanib after sunitinib. Sometimes we do that, but there is no difference, no trials that we see for response. That's the short answer.
Okay, thank you, Dr. Abdulrahim. Question to you, Dr. Ashwaq. I know you chose tissue NGS. Would you consider liquid NGS in such cases?
I'm not really sure about how much the tumor burden, although he had like significant tumor burden, how much circulating DNA. So probably I'll go where the money is. Yani if you have tissue and it's in front of you, you can see his leg, it's huge. You can take a piece of tissue very easily. So probably I'll go more of tissue, but if I don't have other place, or maybe the tissue, the previous tissue was not good enough, maybe that will be another option. Yeah, definitely. I will think about it.
So just I will interject you. I just want to remind people following us and attendee to type their question down if they have any question. Back to you, Dr. Kanaan. And before that, I have small question. For sunitinib and sarcoma, are you one of them, like pro 4 weeks, 2 weeks off, or you use like daily doses, or use 2 weeks on 1 week off? I just want to learn for my future patients.
Usually I give 4 weeks, 2 weeks off, but sometimes when the patient have a lot of toxicity, I usually do the 2 weeks, 1 week off. His thyroid was like, it was messed up with the treatment.
And retrospectively, if you had the NGS done after the first line, are you going to go with sunitinib before using the second line? Or, you're going to exhaust all your lines and think of that?
That's an excellent question.
It's a good question, Abdurrahim. Definitely, I wouldn't use Sutent because I know it's like not a strong drug, and we know the data from alveolar sarcoma in the past that we use Sutent in alveolar sarcoma doesn't work. So if still I have chemotherapy, I was thinking of shrinking his lung mets. I'll still give second-line chemotherapy, even if I have this data. When I failed, yeah, definitely. But I agree with you. It's a good question. Yeah.
That's what I would do as well, Dr. Abdulrahim. And with Sutent, to be honest, I don't have experience of Sutent in sarcoma. I don't use it. I use pazopanib because that's standard offline in sort of third line setting and beyond. However, I have used Sutent in GIST, and I found the 4 weeks on, 2 weeks off, to be honest, a bit toxic on some of the patients. So I used 2 weeks on, 1 week off, and patients somewhat tolerate it better than the 4 on, 2 weeks off. Now, with immunotherapy, Dr. Ashwaq, what's your experience with immunotherapy in soft tissue sarcoma?
Wallahi, Kanaan, to be honest, I've used it in a couple of patients. This is not my first patient. I've used it in an elderly patient with leiomyosarcoma. And another patient, I cannot recall the subtype. But this guy, like, he's 83. He'd been on pembrolizumab for 6 months. Stable disease, no response. And the other guy, I cannot recall, but it gave us some time, it spared us some time, but I did not have any patient have an excellent, remarkable response with immunotherapy. Unfortunately, no. But it gives stabilizer of the disease. Definitely in bone-related, I wouldn't think about immunotherapy at all. There is some few data, but in soft tissue sarcoma, if I have no other option, definitely I would think about immunotherapy.
So one of the trials, SARC-028, it's a phase 2 trial that took a large body of miscellaneous soft tissue sarcomas. Mm-hmm. One of the arms was actually chondrosarcoma, and I think they found some responses in your D-diff chondrosarcoma. Okay. So D-diff meaning high grade, perhaps better response to systemic therapy, but response rates were around the 20% mark. So in later lines, I think this is quite acceptable. I don't have any further questions. Sure, go ahead.
If you allow me, just educate us guys, Ashwaq and Kanaan. So we know immunotherapy, a relation with the tumor burden and high mutational rate. That's why it's working in melanoma, working in lung, slightly in the bladder cancer. Sarcoma is totally different. If you look to the bar graph, it's usually on the right side. So as a one who does not treat sarcoma or does not treat sarcoma like you in every week base, that wasn't one of my first options to think about that. But can you just educate us why it's working differentiated and
usually de-differentiated, it's indicated that it's more of mutation and burden, and probably it's a high grade, and usually response to the usual therapy is lower than differentiated. Differentiated, usually it's sometimes we ignore it, even we don't treat it, even post-op, and even if they left over some of the disease, we just follow up the patient because it will take years and years and years. But even within the, I don't know, it's dependent on the pathologist. Like this guy is high grade sarcoma and his growth rate is very slow. So there is something missing, I think, in the pathology. Maybe if we misread this is a high grade because it's acting like a low grade tumor. And sometimes I think to myself, even if I left this guy without any therapy, would he grow or he will remain the same? Because he was off therapy for 5 years, no diagnosis, no treatment, and he was fine, living a full life with no problem. So I think it's not about like immunotherapy, about a mutation burden, especially in sarcomas. I think we should figure out if we have probably more predictor to response to immunotherapy, so we can select our patient better. What do you think, Kanaan?
So I agree with you, Ashwaq. One of the explanations is actually tumor heterogeneity. So we typically see with some retroperitoneal soft tissue sarcomas that they remain static for quite some time. And then suddenly they take off. They start to grow rapidly. And when they are excised, the pathologist would tell us that there are some areas of well-differentiated areas and other areas that have become de-differentiated. And usually the de-differentiated part is the one that grows rapidly. So we always think about it just like your net, which I'm sure Dr. Mohammed will educate us now. So higher mitoses, more rapid cell division, and hence better or more rapid growth. And these are the types of tumors that you would think may respond better to systemic therapy. Now, just like Dr. Ashwaq said, your well-differentiated tumors, sometimes we don't give any adjuvant therapy after complete excision, although this has a lot of debate in soft tissue sarcoma. Now, going back to where does immunotherapy fit with soft tissue sarcoma? So this is really evolving nowadays. In soft tissue sarcomas, we really cannot we really can't take soft tissue sarcoma as one body. There are multiple subtypes. One of the subtypes, for example, is alveolar soft part sarcoma, ASPS. We know that this is a type of tumor that responds beautifully to immunotherapy. And had specifically combination of immunotherapy plus TKI, such as pembrolizumab, which has been FDA approved based on a phase 2 trial. Other soft tissue sarcomas are perhaps, when we divide tumors up between hot and cold tumors, they're probably more towards the cold tumors. Now, one of actually multiple smaller or earlier phase trials that actually looked at immunotherapy plus minus or combination immunotherapies in soft tissue sarcomas have found really poor responses. However, I think we need to work on certain biomarkers. And biomarkers like your TMB, like your MSI, like your PD-L1 expression.
I think we have still 4 minutes. So 2 basic questions to educate me and maybe some of the audience. The first question, the idea of transformation, you kindly touched on that. Is it something that we see in sarcoma? And the second thing, if you are planning to do NGS, do you do another biopsy or you run it on the first one?
Usually you do it on the primary pathology. Transformation might happen, but I don't think that's common. I have a patient with teratoma who lives 10 years, and after that, it transformed to high-grade polymorphic sarcoma. So you can't tell about transformation from the clinical picture. At that time, it's indicated to take a biopsy. But if the patient the same behavior throughout, you might choose your old biopsy, that will be good enough. But if you think the behavior of the disease has changed, I would do Abdurrahim a new biopsy.
I fully agree with you, Ashwaq. I think it depends on clinical behavior. Some of the tumors that perhaps may transform are your retroperitoneal leiomyosarcomas. Sometimes they remain static. These are your low grade or well diff. Then they de-differentiate and become higher grade, and you see them take off and become larger and cause problems. And with regards to NGS doing it on old or new, to be honest, I always favor doing a new biopsy if tissue is accessible and it's not too morbid on the patients, because we know that tumors actually mutate specifically after therapy.
Great. I think that was a really good case and an excellent discussion. Thank you, Dr. Kanaan and Dr. Ashwaq. If you guys give me a permission, we will move to the second case.
Absolutely.
On our board. Thank you, Dr. Ashwaq, one more time. Our speaker is one remarkable speaker, good friend of mine, Dr. Mohammed Al Garni. Dr. Mohammed is a medical oncologist and section head at National Guard Hospital, and my destiny to follow him everywhere. So in medical school and going to McMaster and maybe in future in National Guard, we don't know. But I'm happy to have him here to discuss challenging cases in NET, neuroendocrine tumor. Dr. Mohammed, the mic is yours.
Thank you very much, Abdulrahim. Assalamu alaikum, Bismillah ar-Rahman ar-Rahim. I would like to thank you, Abdulrahim and Dr. Kanaan for moderating our session today. And it's really a pleasure to have you, Abdulrahim, everywhere. So my task is to talk about just I have a technical issue, but inshallah it will be solved. So my task is to talk about neuroendocrine tumor. I will share my slide now. So this is a 33-year-old healthy female pharmacist, non-smoker. She presented initially as a first visit to our clinic in August 2018. Prior to that, she was seen and investigated in a private hospital for a long history of cough, and due to persistence of symptoms, she underwent CT scans that showed some mediastinal lymphadenopathy. So in the initial hospital, she was investigated by having a PET scan that showed extensive hypermetabolic disease in the chest with multiple lymph nodes in the mediastinum, some bone lesions, and also some breast lesions. So she underwent multiple biopsies there. One from the lung that was remarkable as reported from that hospital. 2 mediastinal samples by mediastinoscopy showed metastatic carcinoma. Another core biopsy from the breast showed invasive mammary cancer with triple negative markers. Then she had endoscopic ultrasound of the pancreatic lesion that showed metastatic carcinoma. So the patient also had right paratracheal lymph node biopsy that showed some atypical cells. And also she had an excision of one of the lung masses that turned to be just hamartoma. So the patient came to the National Guard, and she had a pathology review in our hospital. And the findings showed a tumor that is positive for CK7, CD56, chromogranin, TTF1, and negative for synaptophysin and CD45. The Ki67 initially reported as a high, but when we discussed with the pathologists, they told us it's 70%. And the findings were consistent with poorly differentiated metastatic small cell carcinoma. So as I would do with any patient with a small cell lung cancer, she was started on cisplatin and etoposide for 6 cycles. Initially, after the 3 cycles, she had stable disease. Then she had progressive disease after 6 cycles. She was discussed in the tumor board, and the decision of the board is to move to immunotherapy as a second line. So she was treated with 4 cycles of Pembro, and she had a mixed response. She has disappearance of the pancreatic lesions and some of the abdominal lymph node. However, she developed multiple new subcutaneous lesions. Some of them, they were easily palpable by clinical examination, and some of them, they were very painful. So she was referred to radiation, and she received radiation to some of the this painful skin nodule. But due to the mixed response, I decided to give her 2 more cycles of chemo to declare either she is progressing or responding to immunotherapy. So she received 2 more cycles of Pembro, and she was evaluated after that, and she was started on Zumita as well. And she showed really excellent response to radiation. Now, during this time, the patient is a private patient, and she had issue with insurance, so we couldn't do PET scan. So I decided to repeat her CT scan as a baseline after she finished her radiation to the painful nodules. And unfortunately, it showed that she has now large pelvic mass that is measured about 11 centimeter. And it has some mass effect on the nearby structures. She has also a bilateral inguinal lymphadenopathy. So this patient now, she presented with young patient with poorly differentiated small cell lung cancer. The patient is not smoker. Still, she is in a good functional status, And due to this atypical presentation, we plan to repeat her biopsy, and we decided to repeat the biopsy from the new lesion that appear as a new lesion, which is the right inguinal lymph node. So the right groin lymph node biopsy was done, and it showed well to moderately differentiated neuroendocrine tumor with mitosis of 7 pair high power field. And the tumor is positive to TTF1, synaptophysin, chromogranin, and others, and the Ki67 was 30%. So now we have a new diagnosis of neuroendocrine tumor. So if you look to the classification of the neuroendocrine tumor based on the mitosis, we have the well-differentiated tumor and poorly differentiated. Recently, there is a new group of patients which name high-grade well-differentiated tumor, which our patient falls in this category, where you still have well to moderately differentiated tumor with a feature of high grade, like the high mitosis more than 20 or the Ki67 more than 20%. So our patient falls in this category. So does the patient has new disease, or it's the same process? I think this is, again, back to the discussion that you have in sarcoma. I think it's just the heterogeneity of the disease itself. I think the initial biopsy was one of the area that is poorly differentiated, but it's not really completely different tumor. And when we approach patient with a neuroendocrine tumor, I think it's a multidisciplinary approach. And this is what was done in this patient. She was presented in the tumor board, and she was discussed further in tumor board, as I'm going to mention in the next slides. So what are the factors that we keep in mind when we approach patient or we deciding about the systemic therapy for advanced neuroendocrine tumor? I think it's the relation between the tumor burden, the Ki67, and the rate of progression. The more that you move in the disease volume or Ki67, the more you move toward chemotherapy or PRRT. The low-grade tumor, you are mainly toward the targeted therapy or somatostatin analog therapy. One of the area of discussion is some gray area between the neuroendocrine carcinoma and neuroendocrine tumor, which is related to the Ki67. So at which point that you would consider the patient has neuroendocrine carcinoma rather than neuroendocrine tumor with high grade. It's not really, there is no really clear cutoff. However, one of the studies that looked to the response to chemotherapy based in Ki67, and they used the Ki67 55% as a cutoff point, they found the patient with Ki67 less than 55, they have lower response to chemo, but they have a better survival compared to those with higher Ki67. But you cannot, make this figure as a reference number, but it's one of the efforts trying to address this point. So back to our patient now. She was 2 months after the result. She became more symptomatic. Her ECOG now is 3. She came to the clinic in wheelchair, in pain, depressed, and I was depressed as well. So she became unable to work and to go to do her usual daily activity. And by that time, we get the result of the next generation sequencing for her, which showed that she has ROS1 abnormality. And at this stage, things change for the patient completely. So if you look to patient with neuroendocrine tumor and looking to the molecular profile of those with neuroendocrine tumor, this is a cohort of patients, around 77 patients. They have next generation sequencing information for 63 of them. The most common mutation that you would see is the TP53, especially in patients with poorly differentiated neuroendocrine carcinoma. There are other certain mutations like KRAS and PTEN. However, there are some potentially actionable mutations like PRAF. There are 13% of them, they have PRAF mutation, and the PIK3CA, which you know that we have a medication now for that. And in this study, they found that the TP53 mutation was associated with poor survival. So the patient started inclisitinib on December 2019 at a dose of 250 milligram BID. Within 3 months, the patient back to work with improvement in her echo performance status with no significant side effect. Her repeated PET scan, as you can see, there was time between starting the treatment and time between the PET scan for different reasons. One of them, the patient felt the response herself with melting of multiple of the skin nodules and improving in her pain symptoms, and she stopped taking medication. So she was reluctant to have any sort of imaging, as she worried that there might be some progression. But when we repeat the scan in September 2020, actually she had a good partial response to most of the abdominopelvic lymph node, most of the bone lesion responding, most of the breast lesion disappear. So this is back to our point, whether this is two different diseases. I think it's one disease. However, the initial biopsy was from the more poorly differentiated tumor, and this explained the response in all the tumor sites that she has. So she continued in treatment, and we repeated the PET scan in February 2021. So the study showed no new lesions, which is good, but still showing the hypermetabolic right adnexal and osseous lesions. And it showed also interval resolution of the breast nodules and no more lesions in the breast. So I decided to continue the treatment. Then we have issue with the PET scan in our hospital for the follow-up. So she had it done in outside that showed new right axillary lymph nodes and the persistence of right adnexal mass and osseous lesion. So the patient was very concerned about these findings. I referred her to our radiation oncologist, as I consider this is oligoprogression in one area and we can treat it with radiation. However, when we reviewed the PET scan, it was a poor quality, and we decided to wait to have the PET scan in our hospital before making any further plan. However, because of the patient, she was really anxious and she was concerned about the progression of disease. She got the second line lorlatinib from other place, and the PET scan repeated only 4 weeks after she started on lorlatinib, and it showed persistence of the right distal femur lesions. However, the right adnexal lesion, which was 10 centimeter, is almost completely resolved in her situation. So I discussed this finding with her just a week ago, and we plan to continue on lorlatinib as she already started the treatment, and the PET scan showed quick response to that agent. So what is the summary of this case? Neuroendocrine tumor is a heterogeneous group of disease that can behave in a different way. Always consider discussing the case in a multidisciplinary team. Molecular profile can change the patient life. Actually, this patient was discussed in our molecular tumor board that led by Dr. Kanaan, and we have input from experts from the United States, and we have the plan for the patient based on that discussion with them. And I believe the molecular tumor board is a great learning opportunity for all of us, and it's actually the future of oncology. And if you want to know more about the precision oncology and to have more interesting case, I think I will invite you to our upcoming precision oncology meeting in August 27 and 28. We have excellent speakers and rich program, and I wish to see you all at that time. Thank you very much.
Thank you, Dr. Mohammed. Any great case, great outcome in the end. I'm sure the patient was happy, and I'm sure you are happy as well with the outcome of the patient. And definitely this was a challenging case, and I congratulate you on great management and great outcome for the patient. However, does this happen with everyone? I don't think so. I think she's lucky to have a ROS1 mutation. I do have a few questions for you, Mohammed. One of them is she did not really respond very nicely to immunotherapy. Do you think that since she actually had some radiotherapy prior to starting pembrolizumab, that this may have augmented the response to immunotherapy? And do you know of any association between giving radiotherapy and immunotherapy, some sort of synergistic effect? Now, the reason I'm asking this question is because there are some clinical trials that actually look at this in HCC, specifically looking at perhaps external beam, perhaps looking at transarterial radioembolization, and linking some synergy with immunotherapy.
Thank you very much, Kanaan. So regarding the immunotherapy in neuroendocrine tumor, I think there has been efforts trying to see if immunotherapy works in patients with neuroendocrine tumor. And I think at least for intermediate to low grade, I think the immunotherapy doesn't work. There has been a cohort of patients included in a basket trial design that include high-grade neuroendocrine tumor, and they were treated with EB and Nivo. The combination, they showed some response on patient with high grade. For this patient specifically, I don't think, I think she progressed, although some area responded to the immunotherapy, like in her pancreatic mass that disappeared with immunotherapy. But I'm not really sure if this is the abscopal effect that we have with the radiation. So we know when you give someone radiation and they are in immunotherapy, there is some effect of the radiation that can extend to the other regions, although they were not exposed to the radiotherapy. So I don't think it's the case here, but definitely I think radiation and immunotherapy has some synergistic effect.
Excellent, thank you.
Yeah. In the same context, Dr. Mohammed, thank you for the great case and mashallah, good management. In the same context, using a triple treatment, I mean by chemotherapy and immunotherapy for that patient, do you think that would make any difference? Is there any reason that you selected to go with chemotherapy than immunotherapy?
So thank you, Abdulrahim. I think back to the case, because the first time, and even if I have this case in retrospect, if I have a small cell lung cancer, I think the chemotherapy is cisplatin etoposide plus immunotherapy now is the standard first line treatment. So this is the diagnosis that we have at that time. But if this is a small cell lung cancer, this is the way to go. And if I have this case, again, what's different in this patient is the young age. She is not a smoker. So this is what make you doubt the diagnosis. However, it's always, sometimes you are lucky as a physician when you take the patient around the end of, when the patient exposed to many agents and you have more clear picture about the patient, sometimes you take the credit. Doing something, although if you have the patient in the first place, this is what you would do.
Thank you.
I have a question, but I will let Kanaan go with the next question.
Sure. So I'll actually ask this question from the attendees. A question from Tara Alauddin. The question is, what would the role of PET-CT be in well-differentiated neuroendocrine tumors with regards to staging?
So for neuroendocrine tumor, again, as I mentioned about the classification, it's mainly pathological classification depending on the mitosis in the Ki-67. However, for some group of patients who are in between, there are growing, studies that looking to combining both modality like DOTA scan and PET scan. So if you have a patient who is well-differentiated neuroendocrine tumor, but he's lighting up on PET scan, this means it's not really low grade, it's higher grade. And this is the utility of it. If you have only positive DOTA scan, negative PET scans, you are most likely you are dealing with low-grade neuroendocrine tumor. So is it part of a standard of practice to do PET scan for every patient? No. For this patient, we used to do the PET scan because it's light up in the beginning, and this is how we should follow the patients.
I will go with the next question. It's going to be very basic, Dr. Mohammed. Does the primary site matter? Are you going to look for it? Like, for example, you have something now, a biopsy that's telling you it's triple negative, and you have a behavior of like a small cell malignancy, and you have a mass in the abdomen. So for our learner here, should we, like, for those patients, do, like, for example, the colonoscopy and upper GI or anything? I know that's not going to affect your treatment, but does that give you any information for your option in the future? That's one. And related to the same question, like in the second part, given that you have some issues with the breast, like triple negative, and you have now something that may be coming from GI, does that go with Cowden syndrome and the thing that you treat in your clinic, and does that affect as well the family screening?
Actually, this is not a basic question, Abdul Rahim. This is a complicated question. But for the first part, so is this primary unknown? I don't think it's primary unknown. It's a neuroendocrine tumor. We have the final pathology, but from where it's originated, after having all this information, actually I don't care, because now I know the biology of the tumor. This is a ROS positive tumor, whether it's coming from the lung or it's just a neuroendocrine tumor. So this is how things will move forward. So the biology is what matter in this patient. And I don't think I need to do further investigations, because this will not change much of what I'm doing. Now, having back to the second part of the question, Abdul Rahim, I think it's one disease. If I'm dealing with, really breast cancer and neuroendocrine tumor and other tumor, I would think about really syndromatic things. She has no family history, but she responded, all lesions disappear with the same treatment. So most likely it's one tumor, it's not different tumor, and I don't think screening for that is indicated.
Great.
Thank you, Mohammed. So I don't have a simple question. I have a complicated question. And this is a practical question, because this is a challenge that we see in clinic. I actually have a similar patient to yours, Mohammed. She presented to me with widespread metastatic disease. She was a lot older than yours, but excellent performance status. Biopsy showed this to be high-grade neuroendocrine carcinoma of small cell type. So I actually started just like your patient with carboplatin etoposide. She had great response, but she progressed. But my question is, very frequently we see those mixed responses. And maybe part of this, just like you said, Mohammed, which is the heterogeneity of disease. Some parts of the tumor are probably well differentiated, and other parts are probably less well differentiated or the higher grade. How do you deal with mixed response? And in my case, so she responded, so she had widely metastatic disease, lung, liver, multiple abdominal lymph nodes, and peritoneal disease. One of the liver lesions actually grew uncontrollably on the chemo. So I actually halted the carboplatin etoposide, and I gave her local therapy to this lesion with somewhat good response. But in the end, she actually progressed, and I had to change it to second-line therapy. But my question in general, and I would like to also hear from Dr. Ashwaq, is how do you deal with those neuroendocrine tumors / neuroendocrine cancers when they actually have mixed responses?
So I think, especially when we're dealing with advanced or metastatic setting, I think the patient, how the patient doing is one of the most important factors. So having, for example, I have some patients who are really improved in terms of symptoms. However, the scan sometimes is confusing. So I go actually with the patient. If the patient become less symptomatic and patient is improving, and there is no really strong evidence of, that make me very comfortable to switch therapy, I would continue with the treatment. I would use the same approach that you use with, for the area where there is significant progression compared to other, I might try some local approach. But I think it depends on, by the end, on the patient, how the patient feels, the symptoms of the patient, the burden, which side affecting. So one of the reasons why I continue immunotherapy in this patient, because the question about the progression was in subcutaneous nodule. So the liver, there was no liver mets. The lung, there was no significant lung mets. So it's only just skin nodule, some bone lesions. So in those patients, you might, continue therapy because there is no, physical crisis or something that will affect, the major organ.
Thank you. Ashwaq?
I think if we have like only one lesion that's growing, I would go with the same, just going with local therapy. The other thing I might add, because I have high-grade neuroendocrine tumor of the colon with liver mets, and she failed initially the carbo tobu. I did not honestly switch her to the second line. I was getting the data from the lung, so I give her platinum plus etoposide and atezo, and I'm waiting for the results. So that maybe it works, because we know that high-grade neuroendocrine tumor usually treated as a small cell lung cancer. So what make it different? So maybe she will respond to the combination with immunotherapy. I don't know. She's too young, but her disease burden is significant.
Thank you,
guys. In the same context. Dealing with well-differentiated intermediate or poor, that's the most difficult, I think, patient that we see all the time. Chemotherapy is not working like clinically, and temozolomide doesn't seem, as well, the best thing, and octreotide maybe a little too light for those patients. I don't know, guys, your patient falls in that category with the poorly differentiated, with differentiation, I don't know how to call it. High grade, yes, high grade will differentiated. So how to balance between going to the right treatment, not to go too much, and not to give too light medication? Mohammed?
So for high grade, well differentiated, again, I have to do DOTA scan for those patients, and I need to do PET scan as well. If this is a DOTA scan, AVID only, not PET scan, I will go with the standard therapy, which is the sandostatin or lanreotide, followed by PRRT therapy if the patient progressed, and I will reserve the chemo for the end. If you have a patient who is really having positive PET scan, so this is more likely this is a high grade, so that your options more of toward doing the targeted therapy like Sutent or everolimus if you're dealing with peanut, or moving to chemotherapy from the beginning.
Ashwaq?
I would agree with Mohammed, and again, the clinical picture of the patient can drive you sometime. If your patient progresses very fast, and you might go more toward chemotherapy before trying probably the targeted therapy that works very slow, and it will not respond like very fast. So it's tricky sometimes. There is probably, as Mohammed mentioned, there is no right or wrong. So you might go with radiological, clinical, and make the judgment whether you go from very low treatment, have low toxicity, to high toxicity profile treatment.
Kanaan, do you want to add anything for the next 30 seconds before moving to the third case?
30 seconds, one simple question for Mohammed is, at progression, what would you give?
For this patient?
Yes.
Okay, so I think if she progress, this is the end of it for regarding the ROSE. I'm not really familiar if there is any more targeted agent that we can use. I think she still have the chemotherapy is there, since we know that so the temozolomide is still an option for her.
CAV, Dr. Mohammed, chemo, would you consider that?
I never used it صراحة for my patients. Most of the patient capecitabine and temozolomide works. I have a few patients that I treated them after the standard therapy. For example, I have a patient with gallbladder neuroendocrine tumor, high grade. I treated her as per standard. She received cis-etoposide. She did not respond. Then we gave her temozolomide. She did not respond. So I treated her as a gallbladder. So I just gave her Xelox, and she has very impressive response to Xelox. So sometimes treating as for the chemo that works in certain primary site, it might help.
I have a similar case, a uterine neuroendocrine carcinoma, responded beautifully to cis-etope, then progressed after we gave her a bit of a break. I actually rechallenged her with cis-etope, and she still had a sustained response. So I think we should not forget also about Rechallenge, depending on the duration of time. And 6 months seems to be the time frame that is quoted by evidence.
I don't know about the evidence outside the lung, but maybe topotecan oral, that may be one thing that we can think for small cell, but yes. I have to review actually the evidence for outside the lung. Yeah. Thank you for the second case, Kanaan. The third case.
Sure. So back to Dr. Ashwaq Al Olayan for the final case, which is also another hopefully interesting and challenging sarcoma case.
Yeah, it is interesting, Kanaan, but it's very short. I did not have time to give like too many lines of therapy. So, okay. So my patient now, he's 73-year-old, non-diabetic hypertensive. He was diagnosed with retroperitoneal liposarcoma. It was dedifferentiated liposarcoma. And initially they were mixing that this is a well-differentiated. His story is complex because he presented to one of a private hospital and he presented with bowel obstruction. And he ended up by the surgeon removing his colon and forget about the huge mass lying in the retroperitoneum and end up by colostomy. He came to our hospital to correct the damage that had been done to him. He was seen by our surgical oncologist and who went in there, tried to resect the mass, who get us a better biopsy. And unfortunately, he could not remove the mass because it was so attached to a vital organ, and it was very close to his kidney. And he reconnected his bowel because there is nothing wrong with his bowel except an external pressure from the mass. So we examined the pathology here. It turned to be a dedifferentiated liposarcoma. If you see here, they said we cannot exclude the dedifferentiated, but when we confirm with the pathologist himself, they said it is a dedifferentiated. It was positive for MDM2 amplification. So we'll talk a bit about the dedifferentiated liposarcoma. We know it's happened in elderly people, and the MDM2 can be done by immunohistochemistry or by FISH. So why it's important? It kind of have some certain relationship between the MDM2 therapeutic chemotherapy resistant and certain malignancy, and it showed that it might have some sort of resistance to cisplatin on human malignancy and in vitro experience in a breast cancer with the amplification they found to have resistance to doxorubicin. That's important because this is probably the drugs that, especially the doxorubicin, that the drug we treat most of our sarcoma. MDM2 not contribute to resistant to chemotherapy, but also resistant to radiation. And there is a small data, it was not strong, big number of patients, that patient with, when they use a PD-1 inhibitor like Pembrolizumab in a patient with advanced cancer, if they present with the MDM2 overexpression, they might have tumor progression or even hyperprogression. So again, looking at this graph, that it have been linked to the MD2 to certain factor within the intracellular level that cause tumor progression. And again, if you look to certain medication, Timodal, Gemzar, 5-FU, doxorubicin, cisplatin, and also some of TKA resistant with the presence of that MDM2 amplification. So after we've seen our patient and we thought we're gonna start on therapy, our first choice was doxorubicin ifosfamide because that's the best therapeutic option for dedifferentiated liposarcoma, and he received 3 cycles. And after that, unfortunately, he progressed. So this patient, we did for him right away the NGS because the patient was not really interested in any further chemotherapy, and he mentioned it very well that I'm not gonna do any chemotherapy. So we have, again, the MDM2 amplification. We have the CDK4, which is represent that the patient might respond to ribociclib or palbociclib. And again, we find two of amplification, which is the CD274, which is, again, it's a PD-L1 amplification, which respond to immunotherapy. And again, the BDL1-2 amplification would again indicate. So we have two against one. So what to choose? Definitely, I choose immunotherapy. So again, I was looking what's the importance of this CD274 and expression, and which make the patient candidate for immunotherapy, especially on soft tissue sarcoma. And it's there is a couple of clinical trials. One of them have more than 250 patients, and it was 6 of soft tissue sarcoma were analyzed. And when they were treated with the PD-L1 blocker, when they treated, support that this amplification can predict response to immunotherapy when at presence. So we know these patients with positive PD-L1 expression, they have worse survival. But do we have good data? Because if you look at how many patients have this amplification, only 6 out of 250. So this is a very small number. So it's not really strong data to support. So again, back to our patient. When I tried to look at the PD-CD1LG2, I did not find any data, unfortunately. So he was started to Pembro. Initially, he had a good response in terms of tumor shrinkage, and he's almost 2 years on the treatment with a stable disease and absolutely no side effect. And show you, this is his mass. You look at, there's a lot of necrosis here and cystic component and some calcification. This is his mass after good response to immunotherapy, but more of a cystic component. But the solid component definitely less after immunotherapy. So I was looking, what do we have of data on Pembro on soft tissue sarcoma or bone sarcoma? We have this cohort in 2015. There was around 86 patients, and these patients was receiving Pembro. If you look out of these patients, only 2 they have liposarcomas. And when they look at the good responder, which is amazing, like 5% of the bone sarcoma, they have response, which I thought absolutely they have no response at all to immunotherapy. And 1 of the patient with osteosarcoma and 5 patients with chondrosarcomas. And this is what Kanaan mentioned previously. And none of the patients with Ewing sarcoma have response at all. So that's about my case. Thank you. I told you it's very short.
Yeah, so actually short and interesting. Usually for liposarcoma, the biggest challenge usually for the big centers is the referral from periphery. Because, you know, I think pathologists, they call any fat cells in the retroperitoneal liposarcoma to be in the safe sites. But I know that your case was different, and I'm happy that you did the NGS on the right time and selection of the excellent treatment. The question that I want to ask you guys, usually for liposarcoma, what do you do, guys, beside the chemotherapy? Like, for example, do you need to get general surgery involvement from the beginning in multi-D, or you just go ahead with chemotherapy then decide about those patients? It's a very basic question, but we just want to know what's the excellent triaging for those patients.
Yeah, because some of them, the cases that we thought it's not resectable, but for the surgeon, it is really resectable. But the surgeon attempted resection on these patients and he went in, but he could not resect it. Definitely we have to consult them. Radiation will not be, because of the huge field of radiation. Definitely, it will not be an option. And chemotherapy for possible conversion, but unfortunately, we could not reduce it any further for possible surgery.
Karan?
I agree with Ashwaq. I think it really depends on the location and if the patient is metastatic. Even if the patient is oligometastatic, I'd actually entertain a general surgical consult to see if patients would get surgery with negative margins. If that's the case, that's probably what I would go. If not, so widely metastatic disease or huge unresectable, and the surgeon needs some degree of shrinkage, then I would entertain giving some systemic therapy prior to that. Now, one of the older chemotherapeutic regimens that Ashwaq really loves is the MAID protocol, so triplet chemotherapy. It's a bit old, but you give 3 different types of chemotherapy. So anthracycline, doxorubicin, ifosfamide, and the carbazine. And the objective response rate, so the degree of shrinkage, is much higher, of course, at the expense of some toxicity. So we choose it for well and very fit patients. But if your aim is to actually shrink erythroperitoneal sarcoma to shrinkage to be able to go and receive a radical surgery, or with the aim of cure to get negative margins, then I would consider triplet chemotherapy.
I agree. Yeah, but he's 73, and even with dose reduction, he had terrible course with chemotherapy. And he said, I'm not interested in any further chemotherapy. If he give me the option, I would give him definitely second line.
If you look to the NGS, they pointed as well palbociclib, not in this cancer, but in other cancers. If patient, like for example, elected not to go as well with anything intravenous, like immunotherapy, would you consider palbociclib for those patients, or for this patient?
Definitely, we know the CDK inhibitors been there in sarcoma, and there is some clinical data about that. I cannot recall any one of them now, but there is some clinical data about that. But if you look at the mass, and definitely it will cause a lot of symptoms in the patient, you would think like having palbociclib or pembro more. You think maybe we have more response with pembro, but let's say this patient failed pembrolizumab. I would think about palbociclib as third line of therapy, because he does have the amplification.
If you allow me to comment, Abdulrahim, I think this is an exciting NGS result. And when we think about precision or personalized medicine, you have 4 different types of mutations. You have PDL1, although it says amplification. Yeah. And I know pathologists now, they look at the degree of expression and they give us a percentage number. So I'm not sure what they mean by amplification, whether it's more than 1%, more than 10%. I don't know if any of the attendees, if we have a pathologist attendee who can comment on this. However, there's also PDL2 amplification, your NGS mentioned. It mentioned MDM2 amplification, and it also mentioned the CDK 2/A/B mutation, which responds to palbociclib. I think one of the challenges, and I would like to hear Mohammed Al Garni's opinion on this, is if you have many mutations on your NGS, how do you actually decide what's the driver mutation? Which mutation would you actually target first? I mean, with your case, Ashwaq, I know looking at the patient as a whole, patient is old, patient does not prefer intravenous chemotherapy. Probably one of the first things with the least toxicity, at least, would be to think about immunotherapy. So I would have done the same. But how do you actually decide if this is one of the driver mutations? How do you judge when you actually have multiple mutations? So one of the things that I look at is when I actually do foundation 1, I'd ask them to actually send me the VAF, the variant allele frequency. So which one of those mutations is more abundant in the tumor? and it may help. So probably with Mohammed's case, the ROS1, probably it was the driver mutation, since your patient responded beautifully to a ROS1 inhibitor. But I am interested to hear Mohammed's and Ashwaq's opinion on this.
And for me, I choose Pembro for many things. Number one, we're very comfortable with the medication, that we use it a lot more than palbociclib because we're not a breast cancer oncologist, so we're not using this drug, and we're familiar with toxicity side effect. And since we have two amplification, which is BDL1 and BDL1/2, I thought 2 to 1, so I choose the 2. Maybe Mohammed have a different opinion. What do you think, Mohammed?
So I think when we have any molecular profile reports, it has it's either the result has been studied before. So certain tumor, there is a clear targeted medication for them. However, there are certain mutations that really, even when I get the report, I don't know what to do with them. And the way to deal with this in the right way, actually, has to be discussed in the molecular tumor board. And as long as you have this discussion and you see the input from the biologist, you see how sometimes superficial the way we look to the first page of the report. They have a lot of different insight. They can tell you which can, likely to respond, what is the mechanism of resistance. So whenever you have access to the molecular tumor board, I think this is the best way to go. And I agree with you regarding, how to select in general therapy based on the molecular profile.
Thank you.
Yeah, I see that Dr. Hatem Al-Mughrabi kindly replied to one of the questions by simplifying and answering some questions that mentioned by Dr. Kanaan. And I wanted Dr. Hatem to be around if we have one more question. And the thing that he just identified, the amplification, that you have an increase in the number of copies in the gene, which were calculated by calculating a number of particular gene in comparison to the reference gene. For you, Kanaan, the number of application you mentioned is important to you, like the reference gene, or can you clarify the point that you mentioned when you have a report from Foundation, for example, and you ask for what do you call it, VAE or?
VAF, variant allele frequency. Yeah, I think they mentioned this frequently on liquid biopsies. I haven't really seen it on the Tissue Foundation 1 reports. However, I think you can ask for it. Now, I do with Mohammed a monthly molecular tumor board where we actually get someone from Foundation 1 who can give us a deeper insight on their complicated NGS reports. And we usually have these complicated discussions about what is the driver mutation here, specifically in ones that actually have multiple mutations. It can be challenging to decide on, specifically when you have different mutations and those mutations actually have targets. It can be challenging which drug to actually choose to give the patient as first line or as subsequent lines. Now, I do encourage interested healthcare professionals, if they have if they would like to attend our molecular tumor board, we welcome any input from outside. And if you would like to attend, I'm going to post my email in the chat box for everyone to see. Just email me and I'm happy to actually send you an invite. We have those molecular tumor boards on the third Wednesday of each month between 2 to 3 p.m. Now, going back to Ashwaq's patient. Now, I actually have a question. When was the Foundation 1 requested? What year?
I'm not really sure, wallahi, I can add, but if we're talking about like 2 years back, he's on therapy. That means probably in 2019.
Okay. Now, the reason I'm asking about this is because MDM2 amplification does have phase 1 drugs, I think, and phase 2 drugs available. There are actually many companies that have actually formulated drugs for this that actually specifically target MDM2.
For sarcoma and lymphoma, right?
Yeah, it would be interesting to see how these molecules progress, and I would be excited to actually see if they would be efficacious in liposarcoma.
Yeah, definitely.
And guys, just remind me or educate me. Does trabectedin still play a role for like sarcoma? I know this chondrosarcoma, but what about the liposarcoma? Is it something that you usually use for those patients in the future?
Yeah.
Something?
Yeah.
Okay, so still.
Yeah, it can use it as part of second, or even you can give it in third-line chemotherapy on soft tissue sarcomas.
So with regards to, so excellent question, Abdulrahim, and I think it's important for the audience to hear this, is that trabectedin is actually FDA approved for L-type sarcomas. So for your liposarcoma and your leiomyosarcoma. Now it is FDA approved after progression on anthracycline. So I would consider it probably in third line because of the effectiveness of gemcitabine and docetaxel in the second line. Also, one of the other drugs that may have some efficacy in liposarcoma would be eribulin, which I'm sure my breast oncologists are very familiar with. It is actually FDA approved to be given for liposarcoma after progression on at least one line.
Mm-hmm. Dr. Ashwaq, thank you, Dr. Kanaan, for the comment. Dr. Ashwaq, we know Pembro comes in 2 flavors, 6 weeks and 3 weeks, and this patient is 73. So the 2 questions that I will ask you, the first one, when you consider a patient is old to give immunotherapy, because sometimes the fatigue and tiredness will mask. Is it the age? Is it the disease? Is it the thyroid abnormality or not? And the second question, who you pick for the Q6 weeks?
Okay, for the first question, I think elderly, probably the tolerance for immunotherapy is very good. And I can even refer to more people that I treat with immunotherapy, which is the HCC, and most of them above 70. And the tolerance and the fatigue is not really a big issue in immunotherapy, at least from the patient that I've been treated. In terms of 3 or 6 weeks, I have to give the patient a good period of time or on the 3 weeks. Then I'll assess if we have no toxicity. Again, I can give them the 6 weeks, but again, some of the patient, when they give them the higher dose, they develop toxicity. I have one patient, when I give them the 6 weeks, he developed acute pancreatitis. So I have to go back with the dose of every 3 weeks. But you have to be comfortable, at least after a few months, that the patient have no toxicity, he's doing well, then you can give them the 6 weeks.
Great.
Abdulrahim, if you allow me, I think Dr. Hatem Al-Maghrabi is with us live. So if you can hear us, Dr. Hatem, first of all, I thank you for your comment, very helpful. Secondly, Dr. Hatem, I actually have a question about PD-L1 amplification versus PD-L1 expression. Frequently, especially for lung or thoracic oncologists, for non-small cell lung cancer, they actually look for PD-L1 expression. And we do also ask for this in different diseases. So Dr. Hatem, do you mind commenting on this?
Yeah, thank you very much. I'm a pathologist. I'm a consultant pathologist from King Abdulaziz Medical City, National Guard, Jeddah. We work with a busy oncology group. But just if you want to put it in context, when you talk about expression, you talk about protein. So we test for the protein by immunohistochemistry. When you talk about amplification, you are referring to copies of genes that are increased beyond, we count the genes and then we calculate the ratio. And if the ratio is above a certain cutoff, this is called amplification. So it depends on what is the question you are asking exactly and what are the implications of that particular question in that particular cancer, in that particular individual patient. So the best prototype to sort of understand this concept is HER2-neu. So in HER2, we developed an algorithm that we follow in which we we have studied the association between protein expression and amplification of HER2. And then, so we realized that they are closely, tightly associated. And so we start by doing the least expensive step by trying to study the expression and assigning patient into either negative or positive. And those borderline cases, we refer to HER2 FISH to study the gene itself. So it depends on what are your question and what is the tool you need to answer that particular question. And the same applies in other tumors.
Thank you very much, Dr. Hatem. You're muted, Abdulrahim. Thank you very much, Dr. Hatem. Great input. And I absolutely agree with you. Is about what is the implication of the positive test. So for PD-L1, I do GI. I'm a GI oncologist. In gastric cancer, we actually look at the expression. And the degree of expression is actually predictive of response to immunotherapy. So PD-L1 more than 10% is different than PD-L1 less than 1%. I'm not sure if you have a comment, Abdulrahim, Mohammed, or Ashwaq about this.
No, I don't.
I want to thank Hatem for mashallah tabarak al-mudakhala. I will leave Dr. Mohammed for his comment.
Thank you very much.
Great to have you, Dr. Hatem, and we always welcome your input. Now, I'm wondering if anyone has any final questions before we conclude this session.
Just one comment. Guys, really, I'm happy to be a part of this discussion. And this is the goal of, meeting with our friend and other hospital to discuss, like the new cases. I know that you all on my speed dial calling you for my patient, and I think that's for the patient benefit. And I want you guys to continue this series with more cases. Thank you.
Thank you, Abdulrahim. And again, I thank our co-chairs, Dr. Ashwaq Al Olayan, Dr. Mohammed Al Garni, for hosting the event. Now we are going to be live tomorrow, same time at 7 with more challenging cases. And I'd like to welcome you all to join us tomorrow. Any final comments, Ashwaq and Mohammed?
I would thank you all, Kan'an, Abdulrahim for excellent moderation, and Dr. Hatem for the discussion. Thank you very much, and Mohammed for excellent case. And as Kan'an mentioned, same time tomorrow we have again 3 interesting cases, and that will be monthly. Inshallah, you will have this series of very good cases. And we also encourage people, if they have interesting cases, they can email us. We can put you on the meeting and you can present your case yourself with us. So I would like to conclude. Thank you very much and have a nice weekend. يعطيكم العافية.
السلام عليكم.
مع السلامة.